years. He's a senior consultant now in Great Ormond Street Hospital for Sick Children, with whom I've had a professional relationship for a long time down the A1 and the railway lines in the UK. But without further ado, I'll hand on to Tim. Thank you.
Thanks, John. You're very kind. I'm not sure at what point I became senior, but it's happened. And thanks to the organisers. It looks like a fantastic programme. And I'm talking to you today about protecting the brain and strategies on initiation and later in ECPR. So just need to bear with me. My slides aren't viewing perfectly, but just to say there's been a huge amount of effort to describe neurological outcomes and outcomes in general for paediatric ECPR. And that's over the last 3 decades or so. It's single centre, it's multi-centre, it includes meta-analysis, and it includes large, extensive registry studies that include ELSO and Get With The Guidelines, but there are still very few longer-term outcome studies that tell us about neurology at children that have undergone ECPR. And what difference does that make? Does it make any difference? Well, what we're actually looking at is this interface between CPR and ECMO when we're looking at ECPR. And I've drawn this little Venn diagram, but as you can imagine, if I'd have drawn this 10 years ago, it might look quite different. So it's changed over time. It changes with the age of your patients, with the diagnosis of your patients. It changes depending on what region you are in the world. It changes between centres, and it changes within centres, I suspect, for many of us. But what is clear is that pre-event markers for poor outcome are fairly consistent. And if you look to the left, that's pH prior to cannulation in the event of resuscitation some time ago. And it's the same for post-ECPR or post-event outcomes. The markers for poor outcome are fairly generic across all 3, CPR, ECPR, and ECMO. But what is a consistent trend is that for ECMO, respiratory patients fare better than cardiac patients. And for ECPR, the opposite is true. Cardiac patients fare better than non-cardiac patients. And if you extend that a little bit further to the slide that some of you may recognize at the bottom there, which is a 2-year outcome from the SVR trial, a cardiac study of single ventricle patients that are particularly hard to resuscitate, you can see that it's not actually ECPR that detects your outcome. It's the need for ECPR, ECMO, or CPR that dictate your outcome. So what you can see here is that you can probably mitigate for a lot of the factors there, and it's how you achieve the best outcomes that become important for us. So it's no wonder that ILCOR struggled to come up with strong recommendations for ECPR, whether it's refractory cardiac arrest. They did note that for some patients where physiological CPR is difficult to achieve, or good CPR, efficient physiological CPR is difficult to achieve, it may be better to go on sooner if you have the correct systems in place. But they also noted for the cornerstone of our practice, there are still gaps in knowledge. And if the cornerstone of our practice is restoring nutritive blood flow to core organs at the right temperature and limiting vasoactives and harmful medications, that's quite important. What you'll also note is that there are separate phases of flow and brain injury that occur in the process of resuscitation, and these overlap. They're multifactorial, and they're complex, and they're cumulative. You acquire disease very, very rapidly here. And the problem here is if you are to intervene, at what point do you intervene, and what is it you're intervening on? What can you do in this situation? Well, there's no strategy that tells us what flow to deliver for a patient that's been resuscitated on ECPR, but there is expert consensus guidance that we should choose the right cannulation strategy and the right amount of flow for the patient in front of us. And I think there's very little to dispute this, very little evidence to argue against this. And it may be that you need more flow for children with septic shock. But do you always need all that flow? What about low flow? Could we use low flow instead of full flow? And there's no data to support that either. This is a Paedratric model of cardiac arrest that shows standard flow, so 75 mils per kilo for a piglet, versus low flow following a period of cardiac arrest. And what they looked at is carotid blood flow, lactate clearance, NIRS, and inflammatory markers. And what you see is that carotid blood flow starts to diminish within 6 hours, lactate clearance is poorer at low flow, but NIRS and inflammatory markers remain the same, and they conclude that low flow doesn't necessarily lead to benefit in this piglet model. What is clear, though, that standards and safety and processes are important, and you probably shouldn't have your most junior specialist looking after your femoral cannulated VA patient as their leg goes blue, as their head goes blue, and then NIRS is monitoring their left hemisphere. Standards are important when it comes to resuscitation and flow on ECMO. Hypoxia and hyperoxia are obviously been the subject of decades of research as well, both in stroke and ischemic heart disease and tumour biology. But I just want to make a couple of points. Essentially, the first one is that we've all this concept that we've all physiologically been to Everest. If you are a mountaineer and you've acclimatized, you can tolerate hypoxia. You can tolerate PO2s of 3 and desaturate, and you won't be shocked, you won't be acidotic, you won't have multi-organ dysfunction, and you can continue to climb. But your PO2 is similar to what you had as a term fetus, and you can tolerate delivery, you can tolerate hyperoxia of delivery without harm, and we're all testament to this, we're all here now. The other thing we're aware of is that that transition isn't necessarily straightforward, and you can develop hypoxia and hypoxic respiratory failure in PPHN, but it may be that that's better termed hyperoxia and organ dysfunction rather than hypoxia and PPHN, or some combination of the two. The second concept is this one of biphasic energy failure that you see in ischemia, not just the brain tissue, but of myocardium, where you have an initial hypoxic kick and the failure rate of the ability to use ATP. You have a latent period, and then you have cellular toxicity, mitochondrial toxicity, your inflammasome kicks in, and you get secondary energy failure. But there's also this pH paradox that occurs early at the point of resuscitation, where intracellular pH is dictated by your sodium hydrogen exporter channel and overcompensates and creates cellular acidosis, whether you're a neuron or a myocyte. And this can exacerbate secondary energy failure. And you can also have this period whereby you have, if you haven't done something already, you've got a 60-minute window in which to try and modulate these effects. And the other concept is one of oxidative stress that is common in both health and disease, but actually antioxidants haven't led to the therapeutic breakthroughs that we'd hoped for. And it's very complex and probably still not poorly understood, or we're not able to target as best we might. But there may be situations in our population where we can do that by administering nitric oxide onto the ECMO circuit, as being tried in Melbourne. But it may be that you're already doing it. It may be that you're already giving SNP as part of your treatment, and patients have been resuscitated onto ECMO, and you're inadvertently giving nitric oxide therapy or dealing with reactive oxygen species. But whether you're a cell, whether you're an animal model, whether you're a patient in ICU, or whether you're an adult on ECMO, hyperoxia is harmful, and this is carried through in the pediatric population as well. If you look to the left, you'll see a study of pediatric cardiac patients in a single center where they describe the incidence of hyperoxia as being around 70%. It is common. And if you have a mean PaO2 of over 193 torr within the first 48 hours of your ECMO run, it may be associated with 30-day mortality, whether you're on less than 30 days, whether you're a year of age, or whether you've had the systemic to pulmonary shunt. And I'll just say again, that's mortality at 30 days. And what happens if you open this up to a bigger population and more centers, and not just cardiac patients, and 14% of which had eCPR, you still see a high rate of hyperoxia. And that hyperoxia is associated with cardiac patients. It's less associated with meconium patients, and it's site-specific, but it is associated with mortality still. Hypocapnia is common as well, and is associated with cardiac patients and eCPR, but it's not, and it's associated with neuro events, but not necessarily mortality. And it may be that changes or the rate of change in your carbon dioxide is more important to your cerebral blood flow or your intracellular pH than the absolute value itself. But either way, there's no equipoise over hyperoxia. It is harmful. The only question that's in doubt is the mechanism of injury and what these children are dying from. Temperature management is something else that's been advocated in terms of the recent ELSO guidelines, although there's no directly comparative evidence. The suggestion that we should avoid hypothermia and use mild therapeutic hypothermia for the first 24 to 48 hours with protocols of care. And you can take this a bit further, as some adults have demonstrated for out-of-hospital cardiac arrest. You can run, if you're an evangelist, 2 separate circuits and achieve cerebral selective hypothermia with a separate circuit giving you cerebral temperatures down to around 30 degrees. But regardless of that, what is known is that from anecdotes, from animal studies, and from conventional and unconventional cardiopulmonary bypass, that the timing of intervention is crucial for protecting the brain, and that's consistent with this model of neuronal energy failure. But the other thing it's important for is therapeutic trials. The timing at which you can intervene is important. THACA was one such therapeutic intervention trial that used therapeutic hypothermia and randomized children within hospital cardiac arrest, and they were randomized around 300 children, of which 192 ended up on ECMO. And there were protocols for therapeutic care, but they received usual care otherwise. Of this group, there was a subgroup analysis of around 147 that received ECPR, with a caregiver neurobehavioral assessment afterwards, with a normative data of around 100 plus or minus 15. And there was a survival rate of 41% in this group. But if you look at their VAB scores, around 50% of the survivors had a drop of 15, and about 2/3 of them had a VAB score that was still above 70. And there was a multivariate analysis that demonstrated that open chest, and for open chest, you can read high quality CPR with less interruptions, had a favorable outcome. In a separate analysis, you see that there was no difference between this eCPR cohort in terms of neurobehavioral outcomes and CPR. But you have to wonder what would happen if there wasn't a delay in consent, that you didn't have to wait 6 hours to consent these patients, and there was a standard of care not just for therapeutic hypothermia, but for post-cardiac arrest care on ECMO. Well, what else can we do? What about with neuromonitoring? Can we do more with our neurophysiology? Can we pick up seizures early? Or can we give drugs like phenobarbital or sodium hydrogen channel inhibitors to try and modulate encephalopathy? And if so, when should you give them? Should you give them on ECMO, or should you give them at the time of resuscitation instead of something like adrenaline when you know you're about to be cannulated for ECMO? And it may be that instead of going, you could use the analogy of donor management, where we swap to preserving a certain organ, that we should actually swap to cerebral protection when we establish that we're going to go on to ECMO as part of eCPR. And there are other things we could look at. It could be that we look at cerebral autoregulation and use that as a therapeutic endpoint for treatment. One of the other things we could look at is personalizing care. So biomarkers of brain injury are coming to the fore, and this is a single-center study on the left that I've selected out for in-hospital cardiac arrest and return of spontaneous circulation. I picked this out because of the standard post-resuscitation care. And they had a trio of biomarkers that predicted mortality at 24 hours. And also 2 of the biomarkers, S100 being neuron-specific enolase, predicted PCP scores at 6 months. And they performed better than clinical predictors of outcome and weren't influenced by cooling. About the same time this study came out, they were completing a therapeutic hypothermia of therapeutic targeted temperature management for out-of-cardiac arrest study in about 700 adults. And they biobanked a series of assays here for subsequent analysis. And what you see here is that one of the markers in particular performs highly in separating out good from poor cerebral performance scores, and performs better than other biomarkers over the same period of time, over the same time frames. But it could be that, and they also outperform clinical predictors like SSEPs and CT imaging, and it could be that we should be using these as therapeutic markers, thresholds for treatment, therapeutic endpoints, but also surrogates for 2-year outcomes, where we don't want to wait, or we still have to wait, but we need something in between. But there's also the possibility that some of these biomarkers in the form of microRNAs or non-coding RNAs could be targets for therapy themselves. So we're we're looking at reperfusion injuries, and we're looking at reperfusion, whether it's coronary or brain, we should be looking at prevention in the first measure. And secondly, we should be looking at timeframes and training that improve our strategies to reperfusion. But we don't have a culprit lesion in our population. What we have is children with multiple sources of injury, and it's a complex population, and we have to be able to define neurological outcomes and their natural history through ECPR, through CPR, through ECMO, to quality of life methods and mapping their neurological deficits. And if we do that, we may have some way of risk stratifying and creating therapeutic thresholds for treatment and intervention and establishing their timeframes. But we will need a framework if we're going to move on from management of gas exchange and targeted temperature control. Thank you.
Thanks a lot, Tim. Great presentation. Now we are going to move on with Dr. Francisco Becasis. Francisco is a pediatric intensivist from